मैसेज यहाँ से दिख जाएगा ना, यहीं पर। हम्म, मैसेज यहाँ से दिख जाएगा ना, यहीं पर। हम्म, मैसेज यहाँ से दिख जाएगा ना, यहीं पर। हम्म, मैसेज यहाँ से दिख जाएगा ना, यहीं पर। हार्ड वर्क में ये करोगे तो कैसे पता चलेगा कि कौन ज्वाइन करा। मुझे ये भी तो देखना ना, ज्वाइन कितने किए। मैसेज यहाँ से दिख जाएगा ना, रूममेट पे, यहीं पर। ये नहीं, इसमें ये करोगे तो कैसे पता चलेगा कि कौन ज्वाइन करा। मुझे ये भी तो देखना ना, ज्वाइन कितने किए। मैसेज यहाँ से दिख जाएगा ना, रूममेट पे, यहीं पर। ये नहीं, इसमें ये करोगे तो कैसे पता चलेगा। गुड इवनिंग मैम, कि कौन ज्वाइन करा।
Yeah, good evening.
Very good evening, everyone.
गुड इवनिंग प्रधान जी मैम।
Yeah, very good evening. Good evening, Tabassum.
Yeah, good evening.
गुड इवनिंग मैम।
Can I quickly check my slides?
या मैम श्योर।
Very good evening, everyone.
गुड इवनिंग प्रधान जी मैम।
Yeah, very good evening. Good evening, Tabassum.
Yeah, good evening. How are you, Pritanjali?
Absolutely good. How are
Can
you?
I quickly check my slides? We have not met quite some time.
Been a
good evening
time.
everyone।
Yeah.
Although you are always there in my thoughts, of course.
Yeah, good evening. How are you, Pritanjali?
Absolutely good. How are
Can
you?
I quickly check my slides? We have not met quite some time.
Been a
good evening
time.
everyone।
Yeah.
Although you are always there in my thoughts, of course.
Yeah, good evening. How are you, Pritanjali?
Absolutely good. How are
Can
you?
I quickly check my slides? We have not met quite some time.
Not sure we don't have participants as yet. It's only four of us that is showing. Although you are always there in my thoughts, of course.
Yeah, good evening. Let's see. If they don't want to, we can postpone it.
you?
Can I quickly check my slides? We have not met quite some time.
Not sure we don't have participants as yet. It's only four of us that is showing. Although you are always there in my thoughts, of course.
Yeah, good evening. Let's see. If they don't want to, we can postpone it. Can I quickly check my slides? We have not met quite some time. So do they
Not sure
join
we
more
don't
on
have
Zoom or
participants
on
as yet. It's only four of
YouTube?
us that is showing. Although you are always there in my thoughts, of course.
We can't hear you. Yeah. Let's see. If they don't want to, we can postpone it.
Yes, yes.
Check my slides.
Yes ma'am।
We have not
मैम
met
on YouTube they
quite some
I
time.
think
So do they
Not sure
join
we
more
don't
on
have
Zoom? I can't hear you
participants as
actually.
yet. It's only four of us
YouTube.
that is showing. Although you are always there in my thoughts, of course.
We can't hear you. Yeah. Let's see.
hello।
If they don't
Yeah,
want to, we can postpone it.
yes ma'am।
Yes, yes.
Ma'am I think majority of the people are like seeing this
So do they
presentation on
join
YouTube
more?
only।
I can't hear you actually.
Oh,
YouTube.
okay. So that would be later or at the same time?
Later।
Okay.
We can't hear you. Okay. Let's see.
hello।
So should are we live? Should we start?
Yes, yes.
Yes ma'am। I think majority of the people
Okay.
are like seeing this
So do
presentation
they
on
join
YouTube. Good evening
more? I
everyone।
can't hear you actually.
So ma'am I'm
Oh,
Dr.
okay.
Pritanjali
So
ma'am।
that would be
I'm
later
from
or
Naina
at the
Gupta,
same time?
associate consultant
Okay.
at
We
this
can't
hospital.
hear you. Okay.
And today I
Let's
shall be
see.
moderating the
So
session.
should are
There
we
is a
live? Should
7
we
session
start?
of
Yes,
Onco
yes.
Ocean, which will be focusing on breast
Okay.
BMG. So today's
do they
topic is
join
on
more? I
accelerated
can't hear
partial
you
breast
actually.
irradiation
Oh,
And to chair
so
this
that would be
session, I would
later
like
or
to
at the same
invite
time?
Dr. Gitanjali ma'am.
Okay.
We can't hear
Madam,
you.
welcome
Okay.
today. I shall be moderating
So
today's
should are we
there are
live? Should
seven
we start?
sessions
Yes.
in Patna, which will be focusing on breast EMG. Today's
Yes.
topic is
So
on accelerated partial breast
I may take
irradiation.
it from there, I
And to chair
suppose.
this
That would
session,
be
I would
later
like
or
to
at the
invite
same time?
Dr. Gitanjali ma'am.
We can't hear you.
Ma'am has
Okay.
gained
So should
she was
are we live? Should we
senior
start?
resident at TMS Mumbai, and she was ex-assistant professor at
Yes.
she has
I
also
may take it from there, I
done
suppose.
erosion
That would be
fellowship
later
at
at the
MD
same time.
Anderson Cancer Center Hospital and Fetus near Gallum, Melbourne, and she has
So should
established the
are
Department
we
of
live?
Radiation
Should we
Oncology
start?
at AIMS Patna with the installment of first LINAC in a government setup in
Yes.
Bihar. And her
I may
field
take
of
it from
interest
there, I
are breast,
suppose. That would be
GI,
later at the
and
same time.
gynecological malignancies. And Madam has published around 70 publications in national and international journals. Over to you, ma'am.
Thank you very much,
First
Dr. Naina.
LINAC in a
And
government setup in Bihar.
as we all know that we have gathered this evening to hear a very, very important topic on APBI, which is accelerated partial breast irradiation, and it represents a significant evolution in the field of radiation oncology for the breast, Dr. Naina, offering a more targeted, time-efficient approach and a more friendly approach given to the patients. There are many benefits on APBI, more of which will be covered by our esteemed speaker, and it Dr. Tabassum, who is evolution professor and as well as senior consultant radiation oncologist, also the convener of the disease management group of breast services at TMH Mumbai. Over to you, Tabassum, for your more of which insightful by our esteemed speaker, and it's Dr.
Thank you, Kritanjali, and thank you, Apex Hospital, for having me here to deliver this lecture. So, in this lecture, we will be seeing the evolution and the recent advances of accelerated partial breast irradiation. Thank you, Kritanjali, and thank you, Apex I will be to speaking about the definition, the rationale of APBI, what are the case selection guidelines, and
and we
what are
have
the recent
the
advances
slides are
of
not
accelerated partial
on
breast irradiation. Dot moving.
the slides
Thank
are
you,
not focused
Kritanjali,
on your
and
topic,
in this
on your
I
talk.
will
They
be
are
to speaking about the definition, the rationale of APBI, what are
Dr.
the
Naina,
case selection
yeah, Dr.
guidelines,
Naina, I
and
think we
what are
have
the recent
the
advances
slides are
of
not
accelerated partial breast irradiation. Dot moving.
the
The slides
slides
are
are not
okay.
focused on your
And
but that I
in
cannot
this
I can only see
to speaking about
my
the
CV
definition,
slide.
the rationale of APBI, what are
Dr.
the
Naina,
case selection
yeah, Dr.
guidelines,
Naina, I
and
think
what
we
are
have
the I'm sharing it
the
again
slides are
of
not I need
accelerated
Dr.
partial
Tabassum's
breast
slides.
irradiation. Moving.
Yes,
I am only
The slides
sharing
are okay.
directly, Kritanjali.
but that I
In this
so I can only
is it
see
fine
my
now? To speaking about
my
the
CV. No, it's still.
definition,
I
the
think they have to
rationale of
stop sharing
APBI,
so
what
that
are
you
the
your
case selection
yeah,
guidelines,
Dr. Naina,
No,
I
it's
think
visible only
I'm
for us.
sharing it
the
again.
slides
Yeah,
are
I
not.
am only
I
sharing
need
the
Dr.
screen,
Tabassum's
Kritanjali.
slides.
Dot
Okay,
moving.
but then it's
I
not
am only
visible
The
to
slides
sharing
are
anyone.
okay.
directly, Kritanjali.
But that I so
Okay,
I can
is
only
it
see
fine
my
now? The others?
no, is it visible? I
For,
think they have to stop sharing
yes, yes.
so that
For
you
us, it's
your
okay.
Okay, fine. So
No,
let
it's
us
visible only
start
for us.
sharing. Yeah, I am only
we need
sharing with the
Dr. Tabassum's
presentation.
slides.
So
Okay,
in
but
this
then
basically
it's not
basic
visible to anyone.
basic definitions, rationale, guidelines
So
for selecting cases for APBI. What are the
is
different
it visible? I
For,
think they
techniques
have
of
to stop
APBI
sharing
yes, yes.
and
so that
For
you
us,
certain
it's
your
okay.
practical considerations
No,
will
it's
be
visible
discussed
only.
along with the recent advances
we need
with the
Dr. Tabassum's
presentation.
slides.
So we
Okay,
all
but then
know the
it's
definition of
not visible to
APBI. It
anyone.
is it consists of two components. One is activation and the other is reduction in the target
Is it
volume.
I think they have to
So
stop sharing.
the
Yes.
acceleration
For us, it's
when
okay.
the conventional fractionation was for 5 weeks, it was a huge benefit of reducing the treatment duration from 5 weeks to 1 week. So the fractions can range from 1 or up to 10 fractions. However, this should be taken as a relative term with respect to the changing dose fractionations for both breast radiotherapy. And the other component is the reduction in the target volume. That is, we are irradiating partial breast giving margin to the tumor bed fraction. Hence, the APBI protocols have been advancing. They have been various protocols focusing on various dose fractionations techniques, and they are also evolving in line with the recent advancements in the whole breast RT. First of all, when conventional fractionation was standard, why APBI became popular? This was because of the high dropout rate after breast conservation surgery, and around one-third of patients did not take radiotherapy because of various problems related to the commitment to the protracted course of radiotherapy, the advanced patient's age, as well as access to radiotherapy due to the travel distance or waiting times. Hence, APBI offered an attractive solution, and we had advances in radiotherapy that enabled hypofractionation, which also amounted to cost saving. And in this way, women were able to receive breast more often able to accept breast conservation surgery. And so the clinico-pathological rationale depends on the patterns of recurrence studies, which also it is known that around 70 to 90% of recurrences occur in the immediate vicinity of the primary tumor. And in patients with favorable disease, the incidence of elsewhere failure is less than 5%. Several mastectomy specimen studies have also mentioned that 1 to 2 centimeter margin around the primary tumor is the residual cancer burden, and hence if we target the favorable disease, the incidence of the tumor bed, it is good enough in patients having favorable disease. So this brings us to the case selection criteria. In 2009, Asso had the consensus statement for case selection, and they had categorized patients into three categories: suitable, cautionary, and unsuitable category. So if you see various factors, the case clinico-pathological factors were taken into consideration, and the age which was considered suitable was 60 and above. However, in 2016, they revised the guidelines and they brought down the age cutoff to by 10 years younger. And in the suitable category, then patients more than 50 years were accounted in the suitable category. And however, these guidelines were based on expert opinions as well as a review of literature, but there were no studies that had actually taken into account the patterns of recurrences related to APBI series. Jack Istro in 2000 also came out with the recommendation guidelines, and they also, in a similar way, divided patients into low risk, intermediate risk, and high risk categories. And what is different from the ASTRO guidelines is they disregarded the grade of the tumor as well as the ERPR status of the tumor. So this is the main difference between the two guidelines, as well as lymphovascular emboli. So that was focal and extensive LV. LV was not categorized. It was the presence of any LV. But at TMH, we had been offering APBI since more than 2 decades now, and even before the ASTRO guidelines were published. And this is the 10-year data of our 10-year results of our data. And here, if you see, we had categorized the patients according to the various consensus statement categories, and when we analyze the local control rates, you can see that none of the guidelines were able to differentiate depending upon the recurrence rates. So so basically, similar to our data, many other data has also been published that these are empirical. They are not based on sound local regional control data. So coming to the techniques, there are a range of techniques that are used for offering APBI, and these can be divided into brachytherapy-based techniques, intraoperative techniques, and external beam techniques. Coming to the brachytherapy techniques, interstitial brachytherapy is the most common and most mature technique that has been very well studied, and there is large amount of data with interstitial brachytherapy. It can be offered in post-operative setting or intraoperative setting. The advantage of intraoperative setting is the direct visualization and ease of implant. It is a single stage procedure, but it requires coordination between the multidisciplinary team. Whereas the post-operative implantation, it offers the greatest advantage is the wound is healed completely and you have the full HPR based on which you can choose the patient optimally. So it begins with careful clinical examination of both the breast and axilla. Pre-treatment imaging has to be reviewed to rule out multicentricity, multifocality, as well as breast density. Pre-operative CT scan can be done for patients who are planned for post-operative implant so that you can know the clarity of the tumor bed, which and preempt any difficulty in tumor bed delineation, as well as the histopathology, specifically the grade, the type of histology, as well as the IHCs and the lymphovascular emboli. So this is an example of the cavity visualization score for one of our patients, and in this, based on the higher the score, better is the clarity, and so in patients who have undergone open cavity surgery, you will see well-defined seroma as well as the surgical clips and the post-operative changes. So they are ideal for APBI. The tumor bed is delineated, and we have to ensure that the delineation is as per the guidelines, and we have check histo guidelines also available for delineation. For it does not recommend non-isotropic margins. It suggests that the margins should be grown anisotropically. So you have to ensure a total safety margin of 2 centimeters, and you have to take the actual sum of the surgical and the added safety margin. So this is an example where you can see that the margins are anisotropic. On the medial side, it is 5 millimeter, whereas it is 10 millimeter on the lateral side, and hence while growing the CTV, you have to take the surgical margins and subtract the prospective margin from 2 centimeters. So this helps in optimally delineating the tumor bed and avoiding reducing the irradiated volume. So these guidelines were again published later on, but before the availability of these guidelines, we used to offer isotropic margins, and we used to grow 1 to 1.5 centimeter margin isotropically. And we then, when the guidelines were published, then we studied what was the impact of doing the margin isotropically and anisotropically, and we found that because majority of the patients had a margin width of around 1 centimeter in our set of 100 consecutive patients, this did not impact much. The conformity was little lower, specifically for patients having smaller implants, and the cutoff we found was 35 cc. Similarly, there was no difference in the implant quality, whether the implant was done intraoperatively or postoperatively, and this we had studied in a cohort of 60 patients. Coming to the minimizing, how to minimize the toxicity, late toxicity, specifically the main disadvantage of the interstitial brachytherapy is that it is an invasive procedure and it also leaves behind the marks over the skin. Though these catheter marks, they do fade with mature follow-up, but still there are sequelae over the skin. And in this study, we had evaluated 100 implants, and we found that there was a correlation in the skin dose and the visibility of the implant, and hence it is advisable to limit the dose to the catheter entry and exit points. We also studied the cosmetic outcome, and this we had done as a cross-sectional study. We had done propensity score matching of 64 APBI patients with 99 whole breast radiotherapy patients, and in our patients also at a median follow-up of 25 months. Cosmetic results were significantly better with APBI, irrespective of the method of rating. As you can see, it is significant whether the cosmesis was rated by a radiation oncologist, a surgical oncologist, or it was done objectively by bcct.core, as well as the patient assessment. So these are the dosimetric constraints that have been given by ABS as well as ESTRO. And if one is doing brachytherapy, one should conform or follow these dosimetric criteria to get an optimal implant. So the results of interstitial brachytherapy are based on the mature 10-year results of the JECISTRO trial. This was a trial done in around 1,200 patients, and here patients more than or equal to 50 years up to 3 centimeter diameter tumor patients were included, and minimum 2 millimeter margin. They did not allow LVSI. And at a mature follow-up of 10 years, if you see the trial population, it included only 11% of T2 tumors, only 15% of tumors, patients were less than 50 years. And this was an extremely favorable cohort of patients. ER negative patients were only 5%, and grade 3 tumors were also only 8%. So the results in this trial, the mature results of patient-rated cosmetic outcome as well as the physician-rated outcome were encouraging, and the outcome with respect to the local recurrence as well as the overall survival were non-inferior. Now, coming to the intracavitary techniques for brachytherapy, the Mammocyte was the balloon catheter, brachytherapy catheter that led to tremendous popularity of APBI. It was US FDA approved in 2002, and over the years, its use increased sharply, and this was not this use was out of label use, that is in outside the trial setting. And this procedure was well tolerated, reproducible, and easy to implant. Hence, it became very popular. So this can also be implanted intraoperatively through the open cavity or by opening the scar in the post-operative setting. And here, the dose is prescribed at 1 centimeter from the balloon surface in the plane transverse to the balloon axis. And it has the shape of the catheter takes the shape of the balloon, and radiation sources passes through this, and there is also an outlet for injection site. So if you see the dosimetry of balloon brachytherapy catheter, you will see that it all depends on the shape of the cavity, and if there is some gap between the lumpectomy cavity and the surface of the balloon catheter, then there will be that this can result in underdose, and the distance from the skin has to be maintained meticulously by 5 to 7 millimeter. Otherwise, that can be resultant skin toxicity in the form of telangiectasias, which had been reported. So the pros and cons include as it is easier, it is less expertise is required, and it has been reported to offer good to excellent cosmesis based on the ASBS registry, and it can lead to near symmetric geometric distribution. However, when the balloon conformance is poor, or there can be balloon rupture, and the tumor cavity is superficial, so there would be inadequate skin spacing, and hence these would be the patients that would not be suitable. And there can be problem in the dosimetry if there is interposition of the air or the liquids. And of course, the balloons are not available in many sizes. There are limited sizes, and they will will not be suitable for irregular cavities. So based on the data that has been published, it has been seen, it is now it is understood that balloon brachytherapy has a single large hotspot at the surface of the balloon, which is unlike interstitial brachytherapy. The series have reported increased risk of infection as well as late complications specifically related to the skin spacing, and which had led to higher skin dose, and it leads to telangiectasia. Ultimately, there were reports also of adverse cosmesis, and one or two publications also warned about increased risk of recurrence and mastectomy rates. So this was the data that was published in 2012, where they showed that the complications are higher in mammocyte, and patients who had undergone mammocyte had undergone biopsy more often. Now, this was not known whether this is because of any toxicity or because of recurrence. And the incidence of risk of mastectomy was 4% versus 2% when the patient had undergone brachytherapy. And in this publication, majority of the patients had undergone mammocyte, and interstitial patients were very few. Hence, this technique has its own disadvantages, and cautionary approach needs to be followed. So subsequent to this, the mammocyte catheter has also evolved, because in order to avoid the single hotspot, new generation balloon catheters were had come in the market, and these were the Contura and the mammocyte multi-lumen applicator. The another one was the Savvy, which was also available in different sizes. Now, coming to the seed brachytherapy, which it is also an important way of method of delivering APBI. And in this, the isotope that is used in this is palladium, and you cannot do this in very large volume implants, so it is PTV should be restricted up to 125 cc, and the peripheral dose that is prescribed is around 90 gray. And this method of APBI has also resulted in late toxicity, specifically in the form of intubation and telangiectasias in around 1/4 of patients. Another way of offering APBI, which is not a very commonly used, and it is an evolving technique, is electronic brachytherapy. So here an X-ray source is used to treat 50 kV X-ray source is used to deliver brachytherapy, and it is a disposable source intended to be used for maximum of 10 fractions. So this had come up in 2009 and 2010. However, this method of APBI is not recommended strongly by ABS guidelines, and it has yet to see the clinical utility in large number of patients. In non-invasive brachytherapy is also another method. Here, what happens is the breast is immobilized within the two mammography paddles, and image-guided target delineation is done based on the clips that are present in the post-operative cavity, and then a collimated photon emission from iridium HDR brachytherapy source is then delivered, and it is the dose is delivered in orthogonal sections in two planes, and this is how the brachytherapy is delivered. So this series of NIBB was published in a sample of 40 patients. The mean tumor size was very small, around 1 centimeter. You can see the tumor bed volume is also so small. It is just 21 cc, and the separation between the breast was around 6.7 centimeter. So the toxicity was low, and there was a correlation of the breast separation with respect to the development of telangiectasias. And in this small series of patients who with favorable profile, they had extremely low rates of local recurrences. Now let us talk about the intraoperative radiotherapy techniques. This offers it refers to the delivery of single fraction dose of RT to the tumor bed during the surgery, and as post surgery the tissue has rich vascularization and aerobic metabolism. It will be more sensitive to the action of radiation, and of course there will be no risk of geographical miss. However, there are certain disadvantages in the form of lack of availability of the pathology, extra shielding that of the operating room, resource intense, and it is an expensive technology. And the most important disadvantage are the dosimetric concerns, because the dose fall off, if you see at a distance of 1.5 centimeter, is very rapid, and hence it is that is the main disadvantage that has also led to unfavorable clinical outcome. So large randomized trials have been done with electron brachytherapy as well as with target, and the 5-year local recurrence rate was 3.3% versus 1.3% in the EBRT arm. And hence, early on, even at 5-year follow-up, there were alarmingly increased rates of local recurrences. Similarly, the Elliott series also reported higher local recurrence rates in the patients who had undergone Elliott. They had delivered 21 gray single dose with Elliott. Hence, these two techniques are not recommended for delivering APBI. Now, let us talk about the external beam APBI data. Everyone knows about the rapid trial, that was the trial that had delivered APBI using 3D conformal radiotherapy, and here they had delivered 38.5 gray in 10 fractions, and they had delivered BID dose. The dose which was given was twice a day. So this was the local recurrence, or the clinical outcome was comparable with the whole breast radiotherapy arm. However, if you see the toxicities were much higher in the APBI arm, almost double. At 7 years, the rate of toxicity was almost the double compared to the WBI. Hence, most of the international guidelines, they have cautioned against the use of APBI due to this increased toxicity. The fat necrosis rate was also 3% versus 1% for WBI. However, the results of the Florence trial that had delivered APBI using IMRT, and here they had used non-consecutive fractions, 30 gray in 5 fractions were delivered, and the clinical outcome as well as the cosmetic outcome and the toxicity outcome were favorable in favor of APBI. The import low trial also tested two strategies of reducing de-escalating. They compared 40 grain 15 fraction to the whole breast compared to one group in which they had given 36 gray to the whole breast, and they coned down, they gave boost of 40 grain 15 fractions, and the other group was partial breast irradiation, which was 40 in 15, but the same tangential field was reduced just to give a margin to the tumor bed. And hence the authors say that this is a very inexpensive technology that can be easily adopted for offering APBI. The NSAPP trial was different from the trials that had been done earlier or discussed till now. Here they had included quite a significant proportion of high-risk patients. And here, what were the high-risk criteria? 19% of their patients were ER negative, 40% compared to only 11% in the brachytherapy trial. Here, for 38% women were younger than 50 years, 27% 27% patients had high-grade tumors, 10% patients had node-positive disease, and 8% were also multifocal. So, as expected, and the most important different age cutoff was used in this. Any patient more than 18 years was allowed in this trial compared to other trials that had accrued more than 40 years women. So if you see, this was an equivalence design. The recurrence-free survival, the absolute difference of 1.6% was there, and the cumulative incidence of IBTR also was 0.7%, but the APBI arm had higher risk, higher local recurrences, and this could be related to the type of patients that they had accrued. When they compared the quality of life, you can appreciate that the quality of life was also not very, I mean, significantly different. In the non-chemotherapy group, there was no difference in the quality of life. Now let us talk about the practical considerations. I mean, what should be the ideal interfraction interval? What is the data for lobular histology? What are the different dose fractionations? And whether APBI can be a strategy for reducing the systemic therapy burden. There are controversies related to oncoplasty, and we'll also discuss the updated consensus statement. So this is a trial phase 2 randomized trial in which the various dose fractionations were studied. Here they have used 3D conformal radiotherapy or IMRT. So the 3D CRT was 3 to 5 beam non-coplanar conformal fields. The clinical target volume delineation was standard. They had given 1 centimeter margin, and the PTV was additional 1 centimeter margin. The mean age was 65 years and the tumor size was 1.2 centimeter. The mean seroma volume was also only 16.5 cc, and the mean percentage of breast volume receiving 95% of the prescribed dose was 20.5%. Both these schedules, they had given APBI using the prescription was 30 gray or 27.5 gray in 5 treatments, and the treatment was completed in 1 week. And they noticed that both the schedules were acceptable with respect to the cosmesis. There is another study, a similar study in which they had offered 27 gray in 5 fractions, and they had compared with the control arm of the rapid trial, the control arm of the WBI arm of the rapid trial, and they also found favorable results. There was no worsening of cosmesis in this daily treatment. This was a study in which they had compared the daily versus alternate day treatment. And here again, we see that 315 patients had received every other day treatment and 159 patients were treated daily. And they could not, they did not record any higher toxicity, acute toxicity, as well as in the form of dermatitis or telangiectasias. So more and more data is available now, which are showing that daily treatment can be safely offered. Coming to this 15-year data in which various dose fractionations schedules had been used. This study from Boston, they delivered radiation at the rate of 4 gray per fraction, and 8, 9, and 10 fractions were delivered in various number of patients. And mini tangents plus electron N-phase photon, or mini tangents with N-phase electrons, or wedge pair photon fields were used. And they also reported that the local failure rates are obviously same. There is no difference, but higher dose levels had higher toxicity in the form of worsening of cosmesis, whether it was rated by patient or physician. This is the data that has been published regarding the safety of offering APBI in lobular histologies. So at median follow-up of 48 months, 39 months, they had reported that the cumulative incidence of local recurrence was just 3%. And hence, in these smaller tumors with lobular histology, the APBI also looks safe. The overall survival was excellent. So these are the various trials, that randomized trials that have been done, and currently RAPID-2 trial would be initiated, in which they are then randomizing patients for 26 gray in 5 fractions WBI versus 26 gray in 5 fractions PBI. Because though they had established the safety of 27.5 gray in their OPAR study, but by that time, when they had started the study, the results of fast forward were not available. That's why in the RAPID-2 they have adopted the fast forward dose fractionation for their randomized trial, and they would be randomizing the same dose for PBI versus WBI. So this is a very important study in which the omission of systemic therapy has been studied by offering radiotherapy. And in this Europa trial, they had offered radiotherapy either with whole breast radiotherapy or with partial breast irradiation, and majority of the patients had received partial breast irradiation. So obviously, if you see, the number of toxicities are much less in the patients who had not received systemic therapy and who had received only radiotherapy. Coming to the discussion of oncoplasty. So OPBS is a form of breast conservation surgery incorporating oncologic partial mastectomy with ipsilateral defect repair using either volume displacement or volume replacement techniques. And contralateral symmetric surgery may or may not be performed. So if the extent of resection is less than 50%, patients are offered volume displacement, specifically if the volume is less than 20%. Various advancement flaps or rotation flaps and transposition flaps are offered. And the advanced form of displacement technique include the mastopexy and reduction mammoplasty, which can be offered in up to 20 to 50% of volume loss. And the other way of doing oncoplasty when there is a larger volume of resection, more than 50%, is the volume replacement, wherein you have to bring in the autologous flap or an implant in the defect. So there are various challenges of offering PBI with oncoplasty. Per se, these techniques are generally required or indicated in patients having larger tumor resection, and so invariably those patients will be unsuitable for PBI. There is a huge discrepancy between the site of initial tumor location and the post-operative bed, because the flaps result in more than 1 centimeter isocenter displacement. And there will be also, in such patients having larger tumors, the residual or uninvolved breast tissue that you can spare will also be less. So if the breast tumor ratio is more than 25%, it is generally not recommended to offer APBI. And because of the distortion of the tumor bed or the clip displacement, there can be difficulties in delineating the tumor bed. More so challenging is the preoperative images that are less likely to be useful for identifying the tumor location, because there are significant changes in the breast anatomy after the surgery. And surgical scars as well as the seroma are unreliable because there is no connection with the location of the tumor bed. Various, hence, APBI in oncoplastic surgery is generally not recommended, and it has to be a very selective or individualized decision if one is considering APBI in oncoplasty. So various dose constraints have also been summarized in this publication, and uh, external beam APBI dose constraints have been summarized in this publication. So if it is of interest, you can refer to this. And this can help in implementing APBI for external beam radiotherapy. So lastly, let us also discuss the recent Astro clinical practice guideline that has been published last year. So the patients that have been strongly recommended are the patients who have all of the factors, having favorable factors like grade 1, 2 histology, ER positive disease, patient having age more than or equal to 40 years, and tumor size up to 2 centimeter. And it is a conditional recommendations for patients having high grade histology, ER negative tumors, or up to 3 centimeter. So the recommendations state that if there are multiple of these factors, then the patient may have higher risk of recurrence. And for patients who are not on anti-HER2 therapy or who have a lymphovascular invasion or lobular histology, PBI is not recommended, but in selected cases, as I showed you the data, there are select case series that have been reported about its safety. And APBI is not obviously recommended for positive nodes, positive surgical margins, or younger patients. With respect to DCIs also, similarly, they have given favorable features and conditional recommendations for DCIs as well. And coming to the techniques, the strongest technique with respect to the local control, that means having similar clinical outcome, 3D CRT, IMRT, and brachytherapy are strongly recommended. But for single catheter brachytherapy, that is the mammocyte, precaution is to be exercised, and because we don't have level 1 evidence. And for IORT, they have recommended against using this as a technique for APBI. If you have to see for the toxicity, with respect to the toxicity and cosmesis, the best recommended technique is the brachytherapy and the external beam radiotherapy technique with IMRT. So these are the also panel recommendations for what should be the protocol for clip placement, and how important it is to document the surgical procedures, and discussing the displacement of and the exact location of the tumor and its tumor cavity walls. So it is important to liaise with the surgical oncologist as well as the pathologist to get an understanding of the surgical procedure. And for oncoplastic surgery, generally APBI is not recommended, specifically if the tumor bed has located from the original site. So this is the same thing that various guidelines recommend strongly: multi-catheter interstitial brachytherapy and external beam radiotherapy with IMRT. Coming to the recent advances, there are numerous ways or options which are available to not only for breast. I mean, the advancements are across all our radiotherapy indications. So, with the brachytherapy also, and with the availability of protons as well as photons, this was a study in which they had compared brachytherapy with photon and proton treatment, and they have reported adverse cosmesis was reported in less than 5%, up to 5% of patients. This is a JECISTO trial in which they have offered very accelerated partial breast irradiation in 81 patients. They had offered APBI over 2 to 3 days. So they had studied 4 fractions or 3 fractions, and both patients were offered perioperatively or post-operatively, and at a median follow-up of 62 months, excellent outcome was reported with respect to breast recurrence, as well as the cosmetic outcome was also excellent. We are also now having emerging data from preoperative radiotherapy. A single dose of 20 gray in this study was offered, and radiotherapy was APBI was offered, and surgery was done 3 months later. So here again they have reported cosmetic outcome was good to excellent in 60%. So there was deterioration of cosmetic outcome in this series. However, in this series, when they did the radiotherapy, the surgery was followed immediately within 72 hours. So the primary endpoint was surgical complications, and they have found encouraging results. Similarly, in this study, they delivered APBI using SBRT using gamma pod, and they found that the major response was found in up to 37% of patients, and that was their primary endpoint. So with this, I would like to conclude that various randomized trials and prospective data from interstitial brachytherapy series have proven its safety and efficacy. However, it is labor intensive and needs high quality assurance to get optimal results. And adherence to the contouring guidelines as well as the dosimetric constraints can achieve excellent outcome. And guidelines also recommend external beam radiotherapy techniques, and they are recommending against the use of intraoperative radiotherapy. And with the numerous advances in the very accelerated partial breast irradiation and preoperative radiotherapy, we are having gaining clinical experience, and these have shown encouraging results. Thank you.
Thank you, ma'am. Very nice and informative session, ma'am. Can we have question and answer? So there is one question from chat. So question is impact of HER2 status on APBI results.
So in our series also, we were initially not offering HER2 positive patients, because they were not able to get the full course of maintenance trastuzumab. But as has been also mentioned in the guidelines, if the patient is receiving full course of, anti-HER2 therapy, it will be still a cautionary recommendation, but we have offered in such patients APBI. We found more recurrences in triple negative compared to patients receiving anti-HER2 therapy, HER2 positive and anti-HER2 therapy.
I think there is no more question, ma'am.
Yes, I think there is no more question, but we can still continue with the discussions a little. I would just like to ask you, what is your take on the hereditary breast cancers patients? Would you like to offer them APBI if the indications are there?
No, I would not be bold enough to offer APBI in BRCA positive patients.
Okay.
Yeah.
The timeline is very important. How early or how late till will you offer APBI to any of your patients? Is there any guidance?
You are asking for intraoperative radiotherapy or post-operative?
Any radiotherapy that you're giving to the patients, what is the timeline? I mean, till when can you offer APBI to these patients?
So, for patients who are who are not being planned for chemotherapy, you can do it anytime up to 12 weeks. So, generally, I would not be very keen to do it immediately within 3-4 weeks, because I want the seroma to settle, and I don't want a very big seroma also. There you should give some time for the seroma to settle. So, typically around 6 weeks, I would be offering after surgery the APBI for patients in post-operative setting.
So is there any difference between the delineation of the cavity for open cavity patients or for those with closed cavity?
Yeah, of course, there is a lot of difference because it depends on the technique that the surgeon has used because uh, there are techniques in which there won't be any the location of the tumor bed would be around the initial tumor location. So in those cases, if you want to do APBI with oncoplasty, where there is no or minimal movement of the cavity walls, then you can still consider doing APBI. But for rest of the other cases, I would not be very keen to do APBI for oncoplasty cases,
And
though
even
there are guidelines published for that.
yes, but even the guidelines that are there, consensus is that with oncoplasty you should avoid doing APBI as
Yeah,
such.
yeah, yes.
So for young patients per se, less than 40, do you have any experience with doing APBI in those category of patients?
No, I would not recommend doing it in less than 40. I mean, NACPP trial was a trial that had you included around 40% of young patients. And that is the reason they had found the trial was negative. They could not prove non-inferiority of APBI because the recurrences were higher in that trial.
So I still think that brachytherapy is the best way to do APBI because you are able to save the skin dose as well as the lung and the heart dose to a larger extent than what.
Hi, Dr. Patanjali. It was
Yeah.
a very nice and healthy discussion, I suppose.
Yes,
Thank
yes.
you. Thank you, both of you.
Okay. Okay,
Okay.
then. Thank you, Tabassum.
Yeah, thank
Okay.
you.
Can we
Thank you.
conclude, ma'am?
Yeah. You just conclude, Naina.
Okay, ma'am. So audience, you can also see the recorded session on YouTube anytime again. Okay,
Thank
thank you, ma'am. Thank you, Tabassum, ma'am. Thank you, Ritanjali, ma'am.
thank you.
Thank you.
Closing the session. Thank
Sure.
you. Good night.
Good
Bye.
night.
Good
Bye.
night.